welcome back to my channel. Hope you all are doing good and have watched my previous videos. This is Dr. Prasanjit Das and you are watching Prasu'S Medledge series. So today I am going to discuss with you gastroesophageal reflux disease. So gastroesophageal reflux disease is defined as complications resulting from the reflux of the gastric contents into the esophagus up to the oral cavity and lungs. So basically we have the stomach here, and when there is a reflux of the gastric content into the esophagus, it leads to gastroesophageal reflux disease, and because of this reflux it can lead to esophagitis, that is called as reflux esophagitis. So reflux esophagitis occurs when the mucosal defense is unable to counteract. In long-standing cases of esophagitis, the lower esophageal mucosa may change from squamous to columnar type. So usually it is squamous and it changes to columnar type. Okay. So this columnar type of mucosa is called as Barrett's mucosa. Now coming to the important mechanisms which are preventing the reflux and reflux esophagitis. First is lower esophageal sphincter, which is actually a tonically contracted circular smooth muscle at the distal end of the esophagus. So this is the esophagus. At the distal end of the esophagus, we will be having the lower esophageal sphincter. Next is that part of the esophagus is inside the abdomen under the diaphragm. So intra-abdominal pressure reinforces the lower esophageal sphincter tone. Okay. Then next is oblique entry of esophagus into the stomach. As you can see, esophagus doesn't enter into the stomach directly. Instead, it has got an oblique entry into the stomach, and this angle here is called as the angle of His. So because of this oblique entry of esophagus into the stomach, there is prevention of the reflux. Next is swallowed saliva. It neutralizes the refluxed acid. Now coming to etiopathogenesis of gastroesophageal reflux disease, first is sliding hiatus hernia. In this type of hernia, the esophagogastric junction slides up through the diaphragm, and this results in loss of obliquity of entry of esophagus into the stomach and loss of the reinforcing effect of the intra-abdominal pressure on the lower esophageal sphincter. So how is it happening? So basically this is the diaphragm. Normally the esophagus will be coming under the diaphragm and then it is connected to the stomach. In case of sliding hiatus hernia, the esophagus along with the part of the stomach will be going above the diaphragm. Okay. So as a result, you can see the intra-abdominal pressure which was acting on the lower esophageal sphincter is now no more acting there because it is now in thorax. And the next thing is that there is loss of obliquity of entry of esophagus into the stomach. So these two facilitate gastroesophageal reflux. Now next is vagotomy. It also reduces the efficiency of lower esophageal sphincter. Then we have pregnancy, obesity, ascites, weightlifting. These are also the factors which are responsible for causing gastroesophageal reflux disease. And cigarette smoking and alcohol act by reducing the lower esophageal sphincter tone. Impaired gastric emptying due to the gastric outlet obstruction. So basically we have the stomach here and it has an outlet from where it is connecting to duodenum. So if there is any obstruction here, so the contents in the stomach will be present as such, and this may lead to gastroesophageal reflux disease. And same reason applies for large volume meals. This also leads to gastroesophageal reflux disease. Next is there are some drugs like beta agonists and calcium channel blockers that also reduce the tone of lower esophageal sphincter. Helicobacter pylori, located in the mucous layer of stomach, may inhibit or exacerbate the acid reflux. Now coming to the clinical features of gastroesophageal reflux disease, first is heartburn, which is also known as pyrosis. So it is deeply placed burning pain behind the sternum which is radiating to the throat. Heartburn occurs on lying down in bed at night and is then relieved by sitting up. Okay, so it occurs during lying down position, and when the patient sits up, it is relieved. Next is regurgitation of gastric contents into the mouth. Aspiration pneumonia, which is a very important complication of gastroesophageal reflux disease. It results from the regurgitated gastric contents. Next is odynophagia, which means painful swallowing. Then we have transient dysphagia to solids, which is due to esophageal spasm, and there is persistent dysphagia to solids, which is due to the strictures which form in esophagus. So dysphagia is basically difficulty in swallowing. So there is transient dysphagia due to esophageal spasm, and persistent dysphagia is due to strictures. Now coming to extra esophageal symptoms, which includes hoarseness of voice, then sore throat, chronic cough, and recurrent aspiration, which I have already mentioned, aspiration leading to aspiration pneumonia. Now coming to the complications of gastroesophageal reflux disease, first is esophagitis, then we have esophageal ulcer. Because of esophageal ulcer, sometimes there can be bleeding which leads to iron deficiency anemia due to blood loss. Then we have Barrett's esophagus, in which the squamous epithelium gets converted into columnar epithelium. Then we can have carcinoma of esophagus, strictures in the esophagus, and aspiration pneumonia because of recurrent aspiration due to gastroesophageal reflux disease. Now coming to the alarming symptoms in gastroesophageal reflux disease, it includes weight loss, then GI bleeding, that is gastrointestinal bleeding, and nausea and vomiting. Now coming to the investigations. So the investigations which we do in case of gastroesophageal reflux disease, first is endoscopy. It helps us to visualize esophagitis and also the strictures. Then we do biopsy, which helps us in confirming Barrett's mucosa and esophagitis. So basically we do endoscopy to visualize esophagitis, and then we do the biopsy of the sample which we obtain during the procedure of endoscopy. Coming to next investigation, that is barium swallow and meal, which can reveal hiatus hernia. And then we do ambulatory esophageal pH metry, which may reveal sudden decrease in intraesophageal pH. This is because of the reflux of the gastric contents into the esophagus in gastroesophageal reflux disease. As a result, there will be sudden decrease in the pH within the esophagus. Now coming to the treatment of gastroesophageal reflux disease, so basically we have general measures, then we have medical treatment, and finally we have surgical treatment. So general measures basically includes weight reduction, cessation of smoking, because smoking leads to decrease in the tone of lower esophageal sphincter. Then we can also give small volume but frequent feeds. Then we can avoid alcohol, caffeine, and late night meals. Avoid weightlifting. Now coming to the medical treatment, liquid antacid is given in mild cases of gastroesophageal reflux disease. Then we have S2 receptor antagonists like ranitidine, which is also given in mild cases of gastroesophageal reflux disease. Then proton pump inhibitors are used in moderate to severe cases of gastroesophageal reflux disease. It includes omeprazole, pantoprazole. Then we can also give metoclopramide, which increases the lower esophageal sphincter tone, and also it promotes gastric emptying. Now coming to the surgical management, in case of esophageal strictures, we have to do surgical resection of the esophageal stricture and surgical return of lower esophageal sphincter into the abdomen and fundoplication. So basically in this, the lower esophageal sphincter goes above the diaphragm, so we have to bring this thing below the diaphragm, that is surgical return of lower esophageal sphincter into the abdomen. And in fundoplication, basically we are having the stomach like this, right? So the upper part of the stomach, it's wrapped around the esophagus, so it finally becomes like this. Okay, and at the end, esophagus will be passing through a canal which is formed by the stomach wrapped around it, so it will be finally something like this, and we have to join this area. So this is basically the process of fundoplication. So in fundoplication, the upper curve of the stomach is wrapped around the esophagus and sewn into place so that the lower portion of the esophagus passes through a small tunnel of the stomach muscle. As you can see here, the esophagus is passing through a small tunnel which is formed basically by the stomach. We have wrapped the upper part of the stomach, that is basically the fundus area, around the esophagus to form this canal. So this is the process of fundoplication. So I hope you are clear with this topic, that is gastroesophageal reflux disease. And after completion of this topic, I am also posting one more video regarding this topic, in which basically I will be doing an active recall so that you can answer some questions, and you can click on the next video shown on the right side of the screen to go to the active recall session, and then you will be perfect with this topic. So that's it guys, hope you like the video. If you like my content, please do like, share, subscribe, comment, and also press the bell icon to get notified whenever I upload a new video. Thank you.